Okay, this is a follow-up on last session's things. So last session we talked about insertional tendons of gastrocs and hamstring, particularly semimembranosus. My question to the team this morning was, how many of you have seen it and played with it? And the answer was, no, they don't present like that. No, they don't present like that. And I will assure you, you are wrong, because this happens to majority of the patients with any knee conditions. So we're looking at footprints of the muscle that is inserting. So we have medial lateral gastroc heads, we have semimembranosus, or short head bifam, or even popliteus. They have very, very strong insertional footprint around the joint. They have very close knitted relationship with the capsule. So when there's anything happening around the capsule, be it a synovitis at the fibrous capsule, membrane that's got thickened, they will react. They react by stabilizing you. They react by tightening up the tissue. So you get this capsular tightening effect. So what you will commonly see in this presentation, so what leads to it? One, you have your easy degenerative meniscus. That one research already tell you. Okay, degenerative meniscus, medial meniscus for example, has close knitted relationship in terms of anatomically with semimembranosus. So anyone pretty much with a little bit more collapse around the knee, they will have some form of degenerative meniscus. Okay, you have synovitis, obviously capsule swelling, all that, and then you have laxity, be the capsular ligaments and are now lax because degenerative process. Then the connective tissue, the contractile element of the tissue will now want to tighten up to stabilize and protect it, which is what you will see in Rajesh patients. Rajesh patients has got sort of adhesive capsulitis. What it means is basically it's a response of the body whereby the shoulder is losing control, so the muscles that's deeply rooted around it will want to contract to stabilize it, which then further worsen the tissue. So now I'm asking you to release the tissue. Okay, I'm asking you to release in this area here, release in this area here. In fact, at this point, on the opposite side is your lateral gastroc head, and just slightly below it is your popliteus tendon starting already. So have a think about it. Okay, so what do we find in objectively? If at this moment you still say you cannot find, you should find a capsular based pattern. Classically, terminal knee extension is a little bit restricted, but sometimes you may not find it fine. Terminal knee flexion, so go into end range, you might find that they are a bit restricted. Sometimes you still don't find it fine. Terminal knee bending, you bend it all the way and they say I feel anterior knee pulling, which is the extensor mechanism. Why so? Because we have a capsule that is stiffened at the back here. Your tibia cannot posteriorly glide, therefore the movement of the anterior part has to move a lot more, therefore you get tightening response around the front of the knee. Hint, hint, it's at the back, not at the front. Alright? If I still cannot find it, fine. Okay, I'm going to ask you to do dorsiflexion and terminal knee extension. But when I say that, do you do dorsiflexion first, then do terminal knee extension? Or do you terminal knee extension first, or you do dorsiflexion? Or in terminal knee extension, you dorsiflex and then you do one without. So that's the gastroc soleus sequence. To assess for this particularly, what you want to do is you want to assess why not full dorsiflexion and push terminal knee extension. Then without dorsiflexion, push terminal knee extension. And I'm sure to you, you will definitely find it. Okay? Because if you were to do terminal knee extension and you check dorsiflexion, let me tell you that dorsiflexion 3 to 5 degree difference, you are not going to be feeling the difference. You're not going to be as sensitive enough to pick up that the upper end of the fibers. So therefore, I want you to start by one, dorsiflex full first. Only then you apply a terminal knee extension as a load. So then you get a lot more sensitive towards the knee spectrum. Okay. Why it is important is also why I'm teaching Nordics today. Is when someone finishes their dorsiflexion ranges when they're walking. So that's going towards early heel off, mid stance type area. Okay, they are not achieving full dorsiflexion because they can't. Therefore, their knee starts bending. then they will start using knee flexor mechanism. So your semitendinosus, any of your gastroc sometimes will be used as a knee flexor. Therefore, all these things get tight, right? And then they have their knee pain presentation. However, if you just try it, that you get into deeper range of dorsiflexion, which you have with terminal knee extended, you start to feel extensor mechanism around the hips. So your adductor magnus, your proximal bifam, your glute max, all those things start to kick in to help you in the propelling of gait of extension. So anyone with this finding needs gait retraining relative to that particular movement at that range. Okay, if need to, you block them, you give them feedback and all that, right? So now if someone is wearing heel wedges out here, they're not going into that same dorsiflexion range, then they will also have lesser terminal knee extension. They will start be utilizing gastroc as a knee flexor, which is the reason why MBT shoes are now out of trend, because they're creating a lot more calf tightening, which calf also is a knee flexor, which then creates a lot more trouble around the knee also in the end, right? They can't terminally extend properly. If they do, they end up terminally stressing in their lower back because they skip the hips. Yeah, done.